The focus is on challenging statistics in public health. We're going to run until about 4 o'clock. Sorry, it's 2 o'clock now. The event will be recorded, as it says there, so hopefully you've received the consent forms for that. We ask you to kindly turn off your camera, mute your microphone, usual etiquette for this session. There will be a Q&A session after each presentation. If you do have a question, two ways. You can either raise your hand, there's a little hand emoji at the top of the screen, or pop a question into chat, and I shall keep an eye on those for you and field those to the presenters. We have 4 fantastic presentations this afternoon for you with a huge range of topics, but all under the heading of challenging statistics in public health. Each presentation lasts about 15-20 minutes or so, giving us 5 to 10 minutes for discussions and questions too. So I think we might make a start. Others might join as we go on, and that's fantastic. So to start us off is Professor Anne John. Welcome, Anne, who's joined us from Swansea University, where she's a chair in public health and psychiatry and based in the population data science centre down there. Focus on suicide and self-harm research, really important areas in public health, and also the PI for the National Centre for Mental Health and the Wilson Centre for Young People's Mental Health here based in Wales. So Anne, over to you. Presentation on how do my feelings become numbers. So I'll hand it over.
My background is I started off life as a GP, and then I did public health. So I worked in public health, and now I have a split role. And I guess the reason I called my talk "How Do My Feelings Become Numbers" is because I think one of the challenges that there's been in terms of statistics and epidemiology is communication of what are often complex analyses and graphs to people, and particularly in the field that I work in, where it's sort of children and young people's mental health and suicide and self-harm prevention. You can often seem like you're being quite cold in the way that you talk about data. And I guess there was one presentation I did at a science festival, and some of the young people in the audience were sort of quite challenged by the fact that we were using their health data to assess their mental health. And one of them actually said to me, "How do my feelings become numbers?" And by the end of talking, it was clear what we were doing, but I think that there is a communications issue. So next slide. So I work a lot in the SAIL data bank, predominantly on data linkage, so where we link at an individual level across lots of different data sets. Now, the reason I've sort of ended up after quite a convoluted career doing my work there is that when you think about lots of cohort studies and questionnaires, those, so questionnaires that go into schools, those who are the most unwell in terms of mental health conditions are often the least likely to participate in those studies. Now, we don't find that to be the case for questionnaires that come to people's houses. There's really mixed evidence about whether those with more severe mental health problems answer those or not. But in schools, there is evidence that young people just aren't there on the days that they're being asked to do things that are unusual. So those are the most adverse outcomes out there. A lot of the measures in a lot of the data that we work with are self-reported. So when you're talking about a term that is so so much in common usage. Unless you're using validated scales, they're quite subject to bias. And even when we do use validated scales like GHQ-12, which I'll talk about later, there's often debate within the field. You know, the work I'm going to present later, I was asked by a psychiatrist, you know, do you really think that these sorts of well-being scores reflect mental health? So, you know, there's difficulties with that. And then when you look at sort of like the birth cohort studies that run for many years, people are often lost to follow up. So, you know, when you think about your original cohort and the people who are answering your surveys in their, you know, 20s, often the people that I would be most interested in are gone. And there's something to be said with like, you can't measure what isn't there, however well designed your cohort is. And then I guess the other issue with some probability sampled surveys and both cohort studies is that for things like schizophrenia and bipolar disorder, so rarer outcomes, we just don't get the numbers. So recently we did in the adult psychiatric morbidity survey, we did a piece of work on problem gambling and suicide. And, you know, and we found significant findings, but I was really aware that it was actually based on 49 people. So some of those problems are partly overcome by using, you know, large scale routine health and social care data at a population level. That sort of secondary analysis is good value for money. And then I think most importantly, it speaks, if you phrase it in the right way, it really speaks to people and not policy members, policy makers and practitioners. So you're really demonstrating things that are in the real world. Next slide, please. So I guess, you know, 2 years ago, when I said that I was an epidemiologist, no one knew what that was. And if I put a graph up in front of some audiences, their eyes would glaze over. I think COVID has changed a lot of that. Everyone knows what an epidemiologist is. People have been looking at graphs every week. And I think one of the things over the last 2 years is I've found myself, I sit on SAGE, I co-chair a subgroup of SAGE SPI-B. I've sat on the Welsh Government Advisory Group TAG and also chair one of its subgroups and sit on its Children in Schools subgroup. And I guess there, it's both a challenge and an opportunity. So all the skills that we've all developed in terms of thinking about what sorts of analyses we do, what are the limitations and challenges of it, mean that you can take those skill sets into those sorts of government advisory roles and interpret the rapidly emerging evidence that is being placed in front of them. So, you know, in some ways, I think all the challenges of statistics became the reason why I ended up in the advisory roles that I did. Next slide, please. So I guess the first piece of work that I wanted to talk to you about was something that's going to be published tonight. So it's hot off the press, and it's to do with mental health problems and education. So there's lots of studies out there that highlight the association between poor education and attainment and self-harm and suicide, and also mental health problems. Now, there's lots of reasons why we think those problems happen. You know, if you don't do reasonably well in school, it has impacts on your life chances and trajectories. It's a bi-directional relationship. Lots of young people who have problems and adverse childhood experiences when they're younger will pick up more as they become older. people go into more low-paid, insecure employment or unemployment. And higher levels of education are linked to higher levels of problem-solving skills. And those, that's one of the risk factors for suicide and self-harm. And so there's lots of work done about attendance, but some of that has tipped into being very much focused on rewarding children who reach 100% attendance. And sometimes there can be very good reasons for not reaching 100% attendance. Next slide. So what we did was within the SAIL data bank, and I know, having looked at some of the names of those of you that are here, that some of you have worked within the SAIL data bank, but for those of you that haven't, SAIL has a split file anonymization approach. So if there's a data set, say like the general practice data set, the clinical information is separated from the identifiable information that goes to a trusted third party, which is Digital Health and Care Wales in this case. And it's given what we call an ALF, so an anonymised linkage field. Now that individual in all sorts of different data sets, so primary care, secondary care, hospital admissions, outpatients, court data, we've done some work with court data, that ALF is the same in each of those data sets because there are 5 identifying criteria are generally the same. So you can basically find that individual within each of those data sets. So in this piece of work, we took the education data set generated through local authorities and held by Welsh Government and looked at levels of absence and exclusion. And then we took an array of different mental disorders because there's lots of theories out there about what sort of mental health problems are associated with absences and exclusions. And I guess one of the things I said about the results of this study is it's sort of not rocket science because unsurprisingly, we found that across the board, so almost transdiagnostically, mental health problems were associated with being absent and being excluded. So we're not doing anything that, we have a hypothesis. You would have not had to knock me over if we hadn't proved it. But the thing about this sort of work is that it provides the evidence and the scale with which people can take action. Next slide, please. So what we found was that, unsurprisingly, across all those disorders, there was, young people who self-harmed were almost 3 times as likely to be absent from school. Now, there was an increase in absences and exclusions across the board in older age groups, so sort of 14, 15, 16. And we think that's about the fact that at those ages, parents start to have less influence over whether a young person goes to school or not. And one of the other things we did that I meant to say was, so there's lots of delays in diagnoses of children with mental disorders. Now, we know about 3/4 of them start before young people reach the age of 24. Now, with that, what that means is that for some, so like schizophrenia and bipolar disorder are very unlikely to be diagnosed prior to the early 20s. But there are impacts in terms of, cognitions and emotion that mean that there will be sort of pre-diagnostic effects in schools. So people will be feeling the impacts of their conditions well before their diagnosis. So we although we looked at education up to the age of 16, in order to address that challenge of knowing that people get diagnosed at all sorts of different ages for different reasons, like, you know, you've got to go to your GP, that's one barrier. Your GP has to recognise that there's a problem. But even if they recognise it, they then have to record it. And so to allow for the timelines across some of those issues, we measured our diagnoses up to the age of 24. We also, for neurodevelopmental disorders, took any diagnoses from birth, because those tend to be diagnosed when people are younger. Whereas things like depression and anxiety, it tends to be when young people are slightly older. Next slide, please. So we saw very similar things for levels of exclusion, except this time the odds ratios were much higher. So a young person who self-harms is almost 7 times as likely to be excluded from school than their peers who don't self-harm. Now, the impact of those sorts of exclusions, you know, across most of the Western world, there's a push not to exclude young people. But I guess what this sort of work can demonstrate really clearly, I don't know if we will yet, is how clear the relationship is between mental health problems and absences and exclusion. And that has the potential to change the story in terms of saying that young people who are excluded and absent are vulnerable, rather than it's about behaviour. And I guess one of the things we said in this piece of work was that there's a real, we collect this data routinely, absences and exclusions. So there is a real opportunity to potentially identify young people who are in need of support at an earlier stage. Next slide. So I'm going to talk about some of the suicide work that we did following COVID. So some of the issues around suicide data is that all unexpected deaths, and suicide counts as one of those, have to have a coroner's inquest. Now, so we usually get an ONS bulletin annually. So usually the stats we're working with are at least a year out of date. Now, during COVID, there was a lot of concern that suicide rates would increase. Next slide, please. And some of those concerns were very legitimate. So I sit on the steering committee of an international collaboration, and we published an editorial early on, and we highlighted things like the sense of loneliness and isolation during lockdown, people's exposure to domestic violence because of stay-at-home orders, financial stresses. So those concerns were not unfounded. However, one thing we do know is that when people report a lot that suicide has increased, or talk about methods, it can make vulnerable people more vulnerable. So, we didn't really, in Wales, we don't have a real-time surveillance system. In England, there weren't many. And so it was really about how the challenge was about having timely data to answer the uncertainty of these questions. So next slide. So what we did was a whole bunch of us, led by Jane Perkis in Melbourne, but with myself in Swansea and David Gunnell in Bristol. We, through the international collaboration, basically set about, it all sounds very easy, but I don't think we could have done it if we didn't have the trusted research environment set up. So we basically contacted people from around the world and asked them for their suicide data. And we published a paper. And we published it at a time when people absolutely did not know what was happening with suicides, and where there was a lot of talk that it had been increased. And that was tied in to all the anti-lockdown movements. So increasing suicide rates was very much part of that anti-COVID measures movement. So it was very vociferous on Twitter, and some of us had some quite challenging Twitter exchanges with people, is how I'll phrase it. So next slide. So we basically sourced real-time suicide data from January 2019, because you wanted pre-pandemic trends, and up to July 2020, but we also had some from October, and did an interrupted time series analysis, so comparing observed and expected data. Next slide. And basically what we found was that suicide numbers had remained largely unchanged or declined in the early months of the pandemic. There were some exceptions to that. In Japan, it started increasing from October, but we think that was related to a celebrity suicide. In Vienna, we're not sure why it was different. In Puerto Rico, and I think this was one of the beauty of this sort of collaboration, I think within statistics, it's really good to work with people who know the context and know the data. Because when Puerto Rico came up, we thought, oh, it must be about economic stresses. But the people we were collaborating with basically said that because of all the storms and hurricanes there, people were still homeless. And so when COVID came along, there was very little community resilience. One of the weaknesses of this study, and we're redoing it, so we've hopefully addressed it in some way, was 16 of the 21 countries were high income countries, and about 40, over half of global suicides are in low and middle income countries. And, these are countries that don't really have the infrastructure, particularly when something like COVID is happening, to develop these sorts of information systems. And I think that is a challenge for the sort of work that we do. Next slide. Next challenge was, so people were, so why hadn't they risen? So we think some of it's to do with increased social cohesion, support from family and friends. Lots of natural disasters are followed by this sort of we're all in it together honeymoon period. There were lots of suicide is strongly associated with unemployment and economic measures. And, lots of things were put in place, which are disappearing now. So we're constantly saying remain vigilant. There was lots of support from services and charities. But, and I think this is one of the risks, so people were very reassured. There was an MP who actually said, oh, well, we don't need to worry about that sort of thing. But, next slide. I think it's always important that we remember that there can be hidden populations and trends within overall rates. And so there's a couple of studies that have come out of the States showing while there was a drop in suicide rates, there was an increasing trend in ethnic minorities. Comes back to all that disproportionate impacts inequality stuff of COVID. And there was a study from Australia about deprived areas. So next slide. So we've extended this exercise. We've got more up-to-date data. We're looking at differences by age and sex. And at the moment, I think we've got 48 countries, data from 48 countries. So it was one of the things I think COVID has done for our community, so people working with data, is really foster collaboration, both across countries, jurisdictions, and disciplines. I've been working with behavioural scientists, sociologists, anthropologists, infectious disease modelers. It's been really different. So what about mental health? So what's been highlighted, I think, during COVID is when you've got rapid emerging evidence, and we set up a living systematic review. So next slide, is quality of data. So, we saw loads of studies being published with no pre-pandemic measures. So there was no concept of any pre-existing underlying trends. Lots early on, there was no discussion about seasonality, sampling frames, the number of convenient samples that were, splashed across the headlines without any of the caveats around that when you're doing that sort of analysis. People literally ignored response rates. And then we talked about self-report and clinical significance. So I think it's really important that, and I know you all know this, about the design of data. So even panel surveys, don't measure the people who aren't in them, even though we call them representative. So we wrote an editorial about that called Says Who, The Significance of Sampling in Mental Health. So I've got a couple of minutes. I'll run through quickly about mental health. Next slide. So this is about GHQ. With GHQ, the lower the score, the lower the levels of mental health, and it does measure diagnosable mental disorders. So during the pandemic, there was that initial drop, which is the line going up, in mental health across the population. Things improved a bit from July, but we have not and continue not to have reached pre-pandemic levels. So, and then the next slide, was a piece of work that I was proud to be involved with. It was led by Matthias Pearce in Manchester. And it basically, we're using the Understanding Society survey here, which is a probability sampled cohort. And we basically did a latent class analysis. And what we identified was for about 70% of the population, so the light blue line and the purple, they were sort of consistently okay during the pandemic. The light green line showed people whose mental health sort of deteriorated immediately, back in March, April, but then they sort of recovered as well. And then we're left with the 11% of the population with the red and dark green lines. And with those people, their mental health was either consistently poor throughout or deteriorated. And within those two groups were young people, people from ethnic minorities, people with pre-existing mental and physical health problems, and those from deprived communities in terms of employment and income. So I think it really highlights how I guess the disproportionate impacts of the pandemic. And I really do think people working in epidemiology and statistics have really been able to put evidence behind what we all know to be true. Next slide. So what's the point of it all? I think we always have to, one of the challenges of everything that we do is that so much of our data is out of date by the time we get it out there. I think, it used to take 18 years to get research into practice. I think COVID has shown us that doesn't have to be the case. I really don't want to go back to that place. The risk going forward, economic protections going, economic downturn, that loss of that social cohesion, impacts of long COVID, and all the unmet need of people who didn't contact services. Mental health still isn't at pre-pandemic levels. You'll see a lot of stuff out there about increases in suicidal thoughts. And it does look like that did happen. But there's a very complex relationship between suicidal thoughts progressing to behaviours. And I think that's sometimes, I think when we report on things, we have a responsibility to talk about those issues. So I guess my two big messages is that, we all have to, I guess as a society, we need to remain vigilant. And our role in that is to keep providing the evidence about what's happened and who it's happened to. And, I just put Build Back Better because I hope we do, but the last 2 days makes me slightly unhopeful. Thank you.
Thanks, Anne. That was just fantastic. Really fitted with the title of today. So kind of challenging statistics in public health, both in the generation of those statistics and also the challenges in the messages that the data shows actually, and really highlighting some of the disparities, both in the direct and the indirect impact of COVID. And fascinating to see how it took a pandemic actually to get the international collaboration, the use of the TRE or the trusted research environments, that kind of speed that sometimes academia doesn't tend to move at that speed, but it's certainly demonstrated that it can. Questions from the audience, or anyone wants to ask a question for Anne, do pop them in and or pop your hand up. And if you do, then just shout. And really handy as well. And is it okay for us to share your slides? I should have asked actually before with the group. Later.
Yeah. Later. Maybe tomorrow would be better.
Post publication, fantastic. Get the paper out. Wonderful. I've one question for you, which was a really interesting one that was kind of one that you popped in at the end about the ability in linked data to identify people early that might be in need of more support in that school environment in particular. There's a lot, isn't there, on whole school approaches to mental health and supporting individuals. I'm just interested, is there something in the wings that's developing in that space?
So there's lots that they've set up already. I think over the last few years, there's been a real transformation in that recognition of schools as a place where we can deliver and support. But I think we're hoping to use this and some of the other papers we've done in this area to work with others across the country, really, to make more use, one, of the data that schools generate, because really they can identify these young people themselves, and then use that to push for more integration across education and health.
Fantastic. And that generating that evidence, much as was done there with the suicide, to inform the policy action in that space. So how can we get more upstream, downstream, and the prevention side? Fantastic. Thank you ever so much, Anne. We're moving on now to our second speaker this afternoon. Just need to remind myself of our running order. James, I hope James is there somewhere. James White from Cardiff University. You are. Thanks, James. Welcome. Thank you for joining us this afternoon. James is a Deputy Director of Population Health Trials in the Centre for Trials Research here in Cardiff in Wales, and based in Decipher, which is the Centre for the Development, Evaluation of Complexity and Implementation in Public Health. Rolls off the tongue. So James, over to you. And any questions and things, feel free to put them in the chat as James is talking, and we'll pick them up at the end. James.
Anne's teaming up quite nicely in that a lot of the focus of her work and some of the drivers of mental health problems are experience of socioeconomic disadvantage and inequality. I'm going to talk today about one of the more kind of severe and extreme forms of disadvantage, namely homelessness. So just to talk a little bit about the definitions of homeless. Many of you will see in your daily lives people rough sleeping, and some of you may well in your cities and towns be aware of homelessness hostels and refuges and shelters. And these are the most visible forms of homelessness, and form the majority of research into homelessness has been on rough sleeping and hostel people who stay in hostels. But there is other forms of homelessness that also exist. For example, I put there sleeping in cars, people squatting, and there's a larger group of individuals who, for example, live in temporary accommodation, such as bed and breakfast. These may be single occupancy rooms with shared bathrooms and shared kitchens. And also sofa surfing is a form of homelessness where most people first land when they become homeless. Just to contextualize homelessness a little bit, I thought it might be useful just describing the types of individuals who are most risk of becoming homeless. So this is a slide from an annual report. This is the 2021 report from Susan Fitzpatrick that is sponsored by Crisis. And what this shows is this is data from people who present in local authorities for help with their homelessness. They're at risk of becoming homeless. What it shows is that the majority of people who present are single adults, in particular single adult males. And then the next largest group is lone parents with children, and other groups are less prevalent. This is a study looking at data from the British birth cohort study. This is data which is looking at exposures recorded before the age of 30 and trying to predict the individual's risk of becoming homeless by age 30. And later on, I'm going to be presenting some data from the British birth cohort study. So this provides some useful information. So I've ringed in red there the factors which are associated with an increased risk of becoming homelessness. And then namely people living in rented accommodation, people who've been care experienced, use serious drugs, not living with natural parents, and are also living in rented housing later on in their early adult life as well. And across the data and across a number of studies, what you will find is that individuals who are at risk of homelessness are much more likely to have a childhood that is characterized by socioeconomic disadvantage, unstable housing. They're often care experienced, report mental health problems, and have lower levels of educational attainment. And I've just written some green factors there, which are factors which reduce the risk of an individual or associated with a reduced risk of becoming homeless. And some of these are geographic, so people living in Northern England and Scotland were less likely. And this is likely to do with the availability of social housing stock and different levels of deprivation across the devolved nations. They're more likely to have left full-time education later on in life and also been in relationships. So that may be because people in relationships, you have two earners, they provide a bit of financial ballast to unemployment. This is data from people who report in local authorities for assistance, and this kind of chimes with the cohort data. The people who report for assistance for homelessness are much more likely to have a history of mental health problems, physical health problems, experience domestic abuse, and you can see some other risk factors there. This is the reasons when people report for help, they're asked about why they have become homeless. And it's a real mix of reasons that kind of aligns with some of the risk factors. So family and friend exclusion, people being asked to leave home, young people being asked to leave home by their parents, breakdown relationships and domestic violence, ending the private tenancies as well. Moving on now a bit to show a bit about prevalence. So this is data from an annual survey that's conducted every year, where they count the number of people rough sleeping. And what it shows is that between 2010 and 2017, there was large increases in the number of people who were rough sleeping. And then in 2018, it kind of leveled off with the policy initiative to target and reduce the number of people rough sleeping. And then a sharp decrease was found in 2020. And that coincided with something called the Everyone In initiative. That was when, in the first wave of the pandemic, people who were rough sleeping and also people in homeless shelters were given access to hotels to reduce the risk of transmission. And that was probably mainly, in terms of the hostels, that's mainly because people sleep in large communal areas. In terms of category, if we look at, this is homelessness by category over time, and although rough sleeping is one of the most extreme forms of homelessness, it's by far the smallest proportion of homelessness across time. That's the yellow bars across the bottom. Much larger groups are people who live in hostels, and the largest group by far are people who sofa surfing. This is a prediction from the crisis report on trends of homelessness categories, and that whilst sofa surfing remains the largest group and rough sleeping the smallest group, one trend I would note is the yellow bar there, which is the use of unsuitable temporary accommodation. And this is occurring more and more frequently in recent years, and in part is due to increases in the pricing of rents in the private sector, lack of availability of social housing stock, and it's likely to also be exacerbated by post-Brexit and COVID-related inflationary rises in costs. If we look at mortality in the previous literature, so the evidence here can be quite stark. So the mortality rates in some studies that look at people who are currently rough sleeping or stay in homelessness shelters can be as much as high as standardized mortality rates, can be as much as 10 times that as in the general population. Nearly all the studies are conducted in high-income countries. I've picked out this table from one study, which is a record-linked study in Scotland. And it kind of exemplifies what findings from others, which is that we see particularly high rates of causes of death related to drug use, higher rates of circulatory causes of death and respiratory causes of death in those who are people who in this study were homeless because they had a no fixed abode indicator on the mortality record in comparison to the wider population. This study is by Rob Aldridge and colleagues in UCL, and what it does is it kind of extends the previous study by having a comparator group. This is the far right column, who are people in the most deprived, live in the most deprived quintile areas in England, and these are people who are asking for assistance at hospital and report that they were homeless. And what it shows is that, similar to the previous study, external causes of death, for example, accidents, others like liver disease and those attributed to drug or alcohol use are much higher in the homelessness than the deprived comparator group. And I've also written in green there that the reverse was the case for cancers. So cancers were more prevalent in the deprived group than the homelessness group. And this probably is due to the fact that it takes some time for numbers of cancers to accrue, and that if people are dying at a younger age, for example, from external causes, we're not seeing as many in the homelessness group there, and that they calculated what proportion of these deaths were amenable to healthcare, and that around a third of them in the homelessness group were deemed to be amenable to treatment, suggesting there's an unmet need here. So to kind of broadly summarize the previous studies on mortality, nearly all of the studies have sampled people who are currently homeless and are in the more severe end of the homelessness continuum, namely rough sleepers and those in homelessness shelters, as well as other things such as using the no fixed abode indicator. There's very limited information and almost no studies on the much larger group of people who are sofa surfing, those people who live in bed and breakfast, and then another group which is not a large group but it's been omitted, which is people who squat. There are some notable differences in terms of cause of death and prevalence of cause of death related to external causes and other factors which are higher in the homeless experience than others, but very little information on other factors that may explain these differences. So the overall aims of the study were to estimate the association between homelessness across the full continuum of severity and premature mortality, and explain a range of plausible covariates to explain the associations, and I've listed a few there. So we use data from 2 birth cohorts. So we conducted analyses in each birth cohort, and then we pooled them in an individual participant meta-analysis. The 2 birth cohorts we used were the National Child Development Study and the British Birth Cohort. And I'll be calling these 1958 and the 1970 cohort because that's when they started. And these are ongoing birth cohort studies that sampled individuals who were all born in a week in 1958 or 1970. Some of the good things about these birth cohorts are that they are managed by the same organisation, the Centre for Longitudinal Studies, and that what that means is that there's some harmonisation in terms of the assessments that they use, and also there are harmonisations in terms of the years at which items are assessed. So in the year 2000 and then recently in the pandemic, the same items were presented to people in these 2 different cohorts, which are of different ages. So the exposure in this study was a single item on asking whether they'd ever been homeless, and it was asked at different ages in the 1958 and 70 cohort, and that was defined as having to move out of a residence and having nowhere permanent to live, and excluded people who lived with parents. Those people who said they had been homeless were asked where they'd stayed. So we had options of rough sleeping, hostel squatting, bed and breakfast, and sofa surfing. And the wording was the same across the 2 cohorts. In terms of mortality, people were followed up. The outcome was all-cause mortality and followed up until middle to old age across the 2 cohorts. And majority of those deaths were registered through the ONS, the mortality file, but some are also mocked up through field work where people tracked follow-up studies. In terms of covariates, so the good thing, picking up on some of the points that Anne made, the bad thing about cohort studies is we lose people, and the good thing about them though is that they're often what we call well described. So they have often really detailed individual level measures of potential confounding or mediating variables. So I've listed a few there that we looked into, such as socioeconomic status, self-reported accidents, substance misuse. So, whereas in record linked data, you'll have information on, whether someone has a drug misuse disorder. Here we've got assessments of, the lifetime use of 14 different illicit drugs. We've got information on daily smoking, as well as screening for people for alcohol problems. And we also looked at other factors such as contacts with the criminal justice system and more broader lifestyle variables. I thought I should, given it's an RSS talk a little bit about the statistical methods that we used. So what we did within each cohort, we imputed missing exposure to covariate data. We then did a Cox proportional hazards analysis within each cohort, adjusting for each set of covariates. We looked at some of the assumptions, whether some of the assumptions of proportional hazards models have been violated, and did some preliminary analysis to see if there was any interaction between homelessness and sex. And then, as I just said, we adjusted for the hazard ratio for different sets of covariates. We then combined the result from the 58 and the 70 cohort in a random effects meta-analysis, looked at heterogeneity, and did some sensitivity analyses looking at different substances. So some studies have found that particularly opiate use is much more common as a cause of death within homelessness populations. So we looked at opiates and we looked at separated out opiates from other drugs, and then looked at smoking and alcohol, and also looked at reran the analysis in a complete case sample, just in case. One, there's an assessment of any bias introduced by missingness. Secondly, to see if anything gone awry with our imputation model. So in the pooled analysis, there were around about 23,500 participants. 6.1% said they'd ever been homeless. It was broadly comparable across both cohorts. Nearly 3/4 said they'd sofa surfed. Around a third said they stayed elsewhere. And then options of hostel bread and breakfast use and sleeping rough were around 20%, and squatting was lower. And people could select more than one option. So the most common multiple response is people who had sofa surfed and stayed elsewhere or another place. This is a table showing for each cohort differences between people who had said they'd ever been homeless or not, and an alignment with the data from previous cohorts and people reporting to local authorities for assistance. We find a greater preponderance of socioeconomic disadvantage, mental health problems, and also seeing a doctor for an accident or a violent assault, mugging, and a sexual assault in the homelessness group than the never been homeless group. This is the data, and I think it's as we would expect. The people who have been homeless are more likely to report contacts with the criminal justice system and report substance misuse. One thing I did note there, I've put in green, is that in the 58 cohort, we found more people who were obese who hadn't been homeless than who had been homeless. We didn't find that in the 70 cohort. Mortality, we had 805 deaths. The follow-up was longer in the 58 cohort than the 1970 cohort. This is a forest plot of comparing people who had ever been homeless to people who had not been. And what we're looking at is, for those who aren't familiar, if the lines are to the right of the dot, that indicates that there's an increased risk of death in the homeless than the never been homeless group. And what it roughly shows is that across the models that there is an increased risk of death in the homelessness than the never homelessness group, and that there was some moderate levels of attenuation after adjusting for socioeconomic status, mental health, the other sets of covariates, but the association wasn't fully explained until we adjusted for them all in the multivariable model at the bottom. And then the other thing I suppose I note here is that in the majority of models, there wasn't much evidence of heterogeneity between the two cohorts. This is a sensitivity analysis where we broke down the substance misuse group into the different substances. And there isn't much difference in terms of the pattern of results for the pool across alcohol, smoking, and all drugs or opiates. Although prevalence of opiate use was low, it was around 8-fold higher in the homelessness than the not homelessness group, but that didn't seem to completely explain the increased risk of mortality. This is just the complete case results. So, which in short are, we look at that one there, and we look at that one there, they're pretty much the same. So in the complete case analysis, we had 19,247. And in the imputed sample, it was about 23,500. So there wasn't much difference there. So this is a busy slide, but what it shows is the same thing as the previous slide. This is in the imputed sample, and this is by different types of homelessness. So we're comparing here people who had reported rough sleeping in comparison to those who had not. And then across the various adjustments going down. The kind of headline results is that the largest hazard ratios are pretty much as we expected for those people who reported squatting, rough sleeping, and staying in hostels. Hazard ratios were somewhat lower for bed and breakfast use and sofa surfing. Nonetheless, in these larger groups, more prevalent groups, the risk of mortality was still elevated, and then became explained as we kind of added more and more adjustments in the model. So in terms of limitations, in all cohort studies, loss to follow-up is a problem. So we included around 70% in the 58 and 8% in the 1970 cohort of people who were originally recruited. We did impute the data, and the results from the imputed and the complete case look comparable. But there may be some sort of hidden, non-ignorable missing data generating mechanism that we can't completely rule out. And then another more important factor I would say is that because these are household surveys, to be included in these surveys, you had to be present at a household. And so we're probably looking at people which have have been homeless rather than people who are currently homeless. And that's very different to the groups of studies which look at rough sleeping and hostels in particular, which are nearly all for people who are currently homeless. So it's likely that in our study that the distribution of risk factors is probably a little bit lower than in those studies. Conclusions, I suppose the main conclusion is that we found that across the full continuum of homelessness experience, mortality rates were elevated. We replicated the established risks for rough sleepers in hotel and people sleeping in hostels. But we also found that for the larger group of people sofa surfing and staying in bed and breakfasts, the elevated mortality rates were elevated there as well. And I suppose more kind of an interesting thing that, often in my work in cohorts, we're looking to try and see if there are factors which explain these. And often we're looking for one thing we can pin our hopes on because we can then intervene and do something about it. But we didn't really find there was one factor. It was more just that across a range of explanatory factors, they all attenuated and explained a little bit of that increased mortality, but there wasn't one factor that was particularly influential. And in terms of implications of the results, I suppose, what it does suggest is that whilst, it's good to move people from who are rough sleeping hostels into low-cost hotels or bed and breakfast, that those people are still at increased risk. And that, if we could move those into stable housing, that would be a better solution. The other thing, I suppose, is that the scope of homelessness prevention really centres on those the hostel users and the rough sleepers. But what this result suggests is that there should be some sort of broadening of the scope of prevention to include these less severe forms of sofa surfing and low-cost housing, low-cost hotel or bed and breakfast use. And then so the other thing I'd note is that these data are freely available. So if you're a UK academic, you can download this data. You can seek to recreate our analysis if you wish. There's also lots of other exposures and covariates out there related to homelessness and other forms of socioeconomic disadvantage that you can analyse. So if you're a junior researcher and you want to access some data, I'd encourage you to look at the UK Data Archive. And they're my collaborators, and the paper's coming out soon in IJ, hopefully. There's my references. And that's it.
Alicia, you're on mute.
No. Oh dear. And I'm on double screen because I think, James, you're still sharing.
Okay.
There we go.
Okay.
Oh, I can't believe it was me that was on mute. Thanks, James. What I was saying was that was fantastic, really comprehensive overview of homelessness, but also the social factors. Again, any questions, do drop them in the chat or pop your hand up, and we can ask James. The other fascinating thing was in those two cohorts at very different times. Like one in the 50s and one in the 70s, the factors that contribute or are correlated with homelessness are all largely the same. And if you did that again today, they're largely the same. And it just highlights how difficult it is to really address some of the underlying socio and economic factors that are creating the conditions that are resulting in homelessness. Really, really good stuff. There's no questions for you, James. I think we've linked up, hopefully Giles linked up with the work that she's been doing on homelessness as well in routine data as well too, so fantastic. And wonderful of the cohorts as well to be freely available for those of you that are really interested in getting to grips with that type of data if you haven't done that before as well too. Fantastic. Thank you ever so much, James. If there's no questions, we're going to move on to our third speaker for this afternoon, which is Claudia Respanica. Hopefully Claudia's here, from ONS. Lovely. Hello, welcome Claudia, thank you. Thank you for joining us. Claudia's working within ONS and focusing on the coherence, coherence of health and care statistics. So Claudia, over to you. Really looking forward to this as well.
There we go. Can you see the slides okay?
Yes, that's fantastic.
Amazing. Yeah, thank you for introducing me. And yes, thank you all for joining. And so I'll be talking about coherence of health and care statistics, something a little bit different than the two previous conversations or presentations, sorry, as we will be looking at the challenging nature of health and care statistics in England. I'll talk you through our current work and our plans to improve harmonisation, coherence and accessibility of official health and care statistics in England. Just to give you a very quick outline. So I will talk about the purpose behind the work on coherence and why we actually started this work. I'll talk you through the outcomes of the meetings and conversations that we held, of which are English Health Statistics Steering Group, and also the theme groups. And then I'd like you to see some of the accomplishments and our achievements, such as the landscape, the newsletter. I'd like to show you some of the achievements of specific theme groups. I will also present to you the work we've done on the UK waiting time statistics. And then I'll finish off with the recognition by OSR and our next steps. So the reasons why we started our work on coherence was mainly because of the systematic review by the Office for Statistical Regulation, which was conducted in 2015. The review basically pointed out to a devolved nature of health and care statistics. And by devolved nature, I mean that official health and care statistics are produced were and still are produced by multiple organizations, which are published on multiple websites in different formats with no single point of access for the users and the government. But because of this, a decision has been made between the UK Statistical Authority, the OSR, and also multiple key official health statistics producers to provide a better system that meets user needs and is more coherent. So as a result of those discussions with what we ended up with is English Health Statistics Steering Group. This group was formed in 2015 and it is responsible for coordination and improvement of health and care statistics in England. It holds membership from organisations such as Department of Health and Social Care, NHS Digital, NHS England, ONS, the new organisation, the UK Health Security Agency, and what used to be Public Health England. We also do have some representatives from Wales, I believe. But our main aim is to provide more coherent and accessible statistics. And we're trying to accomplish that through objectives such as remove duplication of statistical releases, harmonize methodology and definitions, increase user engagement, align publication dates, and improve accessibility of statistics. So these are our objectives, which we work towards too. We also ended up creating theme groups. Theme groups are a little bit different than EHSSG steering group, mainly because they focus on a specific topic within health and care landscape. At the moment, we have 17 theme groups. You can see a list of just a few of them on this slide. So we have, example is adult social care, alcohol, cancer, disability, mortality, and many more. Each theme group has different representation from variety of different organisations, but usually NHS Digital, NHS England, Public Health England, ONS. Some theme groups are also UK based. So for example, mortality has representation from Wales, Scotland, Northern Ireland and England. Each theme group has objectives as to identify evidence gaps and policy priorities, avoid duplication, coordinate publication across health and care statistical producers, foster harmonization, identify user engagement strategy, and improve accessibility for the users. So the work of both theme groups and EHSSG is very important, as they work separately to identify the priority topics and kind of work together across multiple organizations and sometimes countries to make the statistics easier to access for the users. And some of the achievements that we have accomplished. So as I mentioned to you, health and care statistics is published by multiple parties and across different websites. And although there is a gov.uk website, it is a little hard to navigate sometimes, and not all publications are that easy to identify on it. So therefore what we've worked on is health and care statistics for England landscape. What this is it's a web page which has all official health and care statistics in England in one place. It allows users to search by keywords, by different filters. It is updated monthly. However, due to the pandemic, we also included COVID-19 statistics, and data on COVID-19 is actually across the whole of the UK. This information is updated weekly. So we have written multiple articles on the landscape trying to raise the attention of it, one of which was the Social Research Association article. I've included the links in this slide, so after, you're more than welcome to read it. This landscape has been recognised by the OSR, and the link is also on the slide, but I got some screenshots just to show you what it looks like. You can see on top there is multiple landscapes, as different teams within ONS have produced their own landscapes similar to ours. As you can see, you can read about the landscape just here. It tells you what it is, how to use the landscape. And just to, if you scroll down, so it's the same page, just scrolling down, you can see here you can search by particular keywords. You also have an option of filtering by organization, frequency of publishing, by theme. We have a variety of different themes covering stuff like mortality, child and maternal health, cancer, infectious diseases and disability, mental health, and many more. So users can search by this. You can also filter by geographical scale, status, and the date that the publication was last published. And here is an example of what the publications looks like. So you have a title of the publication with the link, then the brief description, and then some information such as the organization, geographical scale, and the theme that it's assigned to. Yeah, so it's quite easy to use, and it's available online for everyone. So our next achievement was our Health and Care Monthly Knowledge newsletter. It is a monthly newsletter which provides a short summary of a few of the most important health and care releases from that month. At the moment, it covers England only, but we accomplished to get over 5,000 subscribers. At the moment, we are trying to understand how exactly our subscribers use the newsletter, how we can improve it in the future as well. I've included the link to the most recent newsletter just to show you what it looks like if you're interested after. And as I mentioned, I wanted to put some spotlight on the theme groups that we've been working on. So Mortality Theme Group, this is a UK-wide theme group. It has representatives from Public Health Wales and Welsh Government. This theme group was active before the pandemic. It used to meet monthly. However, during the pandemic, the team started to meet fortnightly, and it has proven to be highly effective, as it provided a point in which or an option of each organization in each country to come together every 2 weeks to discuss new methodology, to discuss new trends, coordinate publications. And as a result, all organizations publishing new data on COVID-19 were aligning with each other, and the methodology was the same or similar, which allowed actually for comparison across the UK. This theme group has been praised by quite a lot, and we are really grateful for having that theme group, as it was highly effective during COVID-19 pandemic. Another one is the smoking theme group. So what this theme group has identified is that the smoking publications were published by ONS and Public Health England completely at different times in the month. So what this theme group has worked on is to align the publications, and they have been successful. The smoking publications now come out at the same time, which actually makes it easier for the users to see if they try and search for it. They also reference each other in their publications and provide links. So users reading a publication on ONS website has a link available on this publication to go back to PHE and look at their own publications as well. This makes it more transparent, and users are aware of all smoking related publications. This theme group has also identified an evidence gap in smoking prevalence rates by sexual orientation. So as a result, they have worked together to publish something on smoking prevalence of the LGBTQ society. And as a result, the people responsible for policies were actually able to do them and have some evidence-based policy making behind that. And lastly, our last theme group of many that I wanted to bring attention to was the Disability and Unpaid Care theme group. This theme group has worked together to ensure that the measures and methods to measure disability are harmonized. And as a result, they started to encourage data collectors to adopt harmonized measures, and started to look at this at the UK level as well. So they are promoting the harmonized measures across all countries within the UK. And again, this is really important, as health and care statistics are devolved in nature. So making sure the measures and statistics are harmonized allows for better comparison of that statistics and better policy making. So one of the works we have also done, which looked at health waiting time statistics. This is a technical document that we have worked on, So this is a technical document, which looked at what is measured in each of the 4 nation countries. It looked at how statistics are similar and where the key differences were. So the document mainly looked at UK accident and emergency, UK cancer, and UK inpatient, outpatient, and referral to treatment, and UK diagnostic waiting times. So this technical document, it provided a comparison basically of who measures the waiting time statistics in each country, what are the methods, and when do they produce it and how. So this document was very highly requested during the pandemic. As you can imagine, there was a lot of interest from the public and the government on waiting times. unfortunately, this document was produced prior to the pandemic. There were plans to update it. However, then pandemic hit and people across all countries were too preoccupied with the new pandemic publications. However, we are in discussions with people to restart this work and provide an updated version of the same document. So our work has been recognised by the OSR, and as a result, they have closed the systematic review. They have praised our work, and they recommended to progress with further work. And this is exactly what we're doing, and this is what leads me to our next steps. So as you can imagine, the COVID pandemic has had an impact on all of us. This resulted in big changes and shifts in priorities within health and care. And also people across multiple organizations have moved. They have been working on COVID pandemic, and there has been quite a lot of resource issues. Therefore, we have taken a step back, and now we are ready to relaunch the EHSSG and theme groups. And we have created a new work plan to make sure that the actions and objectives are relevant to the new priorities which have come after the pandemic. In order to do that, we have reviewed multiple reports, such as the OSR review of mental health, OSR lessons learned. You can see the list here on the slide. This exercise allowed us to identify priorities within health and care statistics and incorporate them into our work plan. What we have identified is the main top themes, which are communication of data, openness and transparency, data sharing, improved data systems, filling data gaps. It is also worth mentioning that social care, ethnicity and mental health were all repeatedly mentioned across almost all reports as key priority topics. Therefore, what we have done, those top themes, as well as the key priority topics, we have ensured that they are incorporated into our new work plan and the action plans of the theme groups. And as a result, the new vision of the EHSSG is to enhance the coherence, production, dissemination and accessibility of health and care statistics in England, and the aim of reducing duplication, bringing together different agencies to ensure that health policies are evidence-based. So as I mentioned, we also had to relaunch our theme groups. We have interviewed all theme groups leads to identify where they stand, to identify any barriers to change, any priority topics, and have also incorporated that into the work plans. We have also made sure that each theme group has an action point on COVID-19. We have considered creating a COVID-19 theme group. However, we realized that COVID-19 does affect almost all areas within health and care landscape. Therefore, we want to make sure that each theme group has an action point on COVID-19, and we are currently also in discussions how we can incorporate the coherence work at the 4-nation level. There are a few theme groups that already incorporate that, such as mortality. I think smoking theme group also is a 4-nation group as well. So we're trying to work and see how we can do this UK level. So just lastly, our next steps. So we are going to be running a workshop for all theme group leads in December to restart our work. We have now started our regular EHSSG meetings now that the pandemic has calmed down a little bit for now. We are considering to possibly create a EHSSG newsletter to regularly present the work that is being done by us and the theme group. We are thinking of developing new ways of communicating with theme groups, and we are trying to explore new ways of how we can promote our health and care landscape that I have presented to you earlier, as we believe that it will provide one point kind of access for all the users. Yes, which would make it hopefully easier to navigate across the very challenging health and care statistical world. Yeah, so I think that's all from me. But yeah, thank you for listening.
Excellent, thanks, Claudia. I love the dog. That's wonderful. Really, really helpful presentation. And actually, there's a question from Hewell in the chat. Have you got a link to the waiting times, the technical documents, or that you could share?
Yes, yeah. So they used to be available on our website. We do have a GSS website. We did have to take them down due to accessibility reasons, but I can send those documents to you. If you just give me your email or something, I can send them directly to you.
Fantastic. Thanks, Claudia.
Yeah, whoever wants it. Yeah.
The other one that might be useful or of interest to people is the from the ONS, that report on statistics for public good, which kind of puts the framing of the bit that developing that coherence piece. And then in the coherence and the production of those common indicators or data points, are ONS putting out to support kind of transparency and reproducibility, either the code that's used on the routine data to generate the stats, or pointing to the core data sets that are used? Do you think they'll move in that direction?
So yeah, I think we have identified that in our research that people want us to be more transparent. So we are working mostly with not just mainly ONS. It's I think my team kind of tries to coordinate the work of different organizations. So I know some people already put their codes online and they are available. I know NHS Digital, for a lot of their work, has published their work online and some of the coding. I think within ONS, we are moving towards that as well. We do publish some of the work on GitLab, and I believe there is some conversations. I remember some of the teams do want to put their coding online to be more transparent for people. So there are conversations of that. I think people are aware of this hugely. So yeah.
Fantastic. And then another question for you about the different themed groups. I was wondering that as well. Are they invited memberships, or how can you get in touch with the theme group leads?
Yeah, so theme group leads, they usually have a theme group lead leading the theme group. However, usually I think it's mainly through like the word of mouth. So people knowing of who, like trying to get representatives from each organization, making sure that everyone is represented. However, if someone is working on a disability and would like to be part of something, we could put you in touch with the correct person. We have a list of everyone who's the lead and members. We are currently working, so on our website, on GSS website, I can put a link to that website. We have a list of all the theme groups, as well as the names of the members of each. At the moment, they are out of date because of the pandemic. Everyone just moved. People were kind of pulled left, right, and centre to work on different publications. And obviously, Public Health England no longer exists as well. So that needs to be updated. However, that's what we are in the process of doing at the moment. We have our theme group workshop at the beginning of December. I think Dorothy just posted our link to the website, but I can pop my email in the chat as well. So if someone would like more information about theme groups, I'm more than happy to exchange some information as well.
Fantastic. Thank you so much, Claudia. It's been really interesting to see what has been happening and also what's to come. And the questions, I think, highlight that actually people are are really interested about linking in more on different levels in that too. So thank you ever so much.
No worries.
And last but not least, we're moving from system-generated health death type data to user, public, individual generated data. So welcome to Nina De Cara and Valerio Maggio from Bristol University, who are going to talk to us a little bit about the application of more data science approach to Twitter type data. So over to you.
First of all, thank you so very much for inviting us. It's been a very interesting afternoon today, it's actually a pleasure to get the chance to present the work Nina and I are doing in understanding what is the potential of using Twitter to study population well-being. So let me just briefly start by introducing the team. We're part of the Dynamic Genetics Lab, who's co-led by Claire and Oliver. Claire is professor on the School of Psychology and Turing Fellow. Oliver is a associate professor on statistical genetics of the MRC Integrative Epidemiology Unit in medical school, University of Bristol, and Turing Fellow. And so this lab is a cross departmental unit, and the core research of the lab is focused on exploring how genetics and environmental influences change through time and space, and in response to intervention. In particular, the work Nina and I are doing is specifically focused on social media data. And so, talking about challenging statistics today, we explore the utility of using structured data from social media, in particular from Twitter, to understand population mood and well-being. And we're going to present today two research work we're currently doing, showing evidence from two different perspectives. In the first part, I'm going to talk about a population well-being in Wales during COVID-19 pandemic. This work done in collaboration with Public Health Wales and funded by the Health Foundation. And in the second part of the presentation, we'll be talking about, we'll hand over to Nina talking about linking Twitter in a UK birth cohort study. So giving you another possible research perspective in using social media data. So moving from population data to individual level data. So I'll be talking about the first part. So population well-being in Wales now. And for those of you not very familiar in how Twitter data work in general, and how collecting data from Twitter works, it all starts with, so first of all, it has to be said that Twitter provides what they call the Twitter Academic API, which is an extended version of the application programming interface, so API, who's the programming framework that allows you to get data from Twitter in a systematic way. And they just this year, January 2021, they launched this new academic API program, which essentially made life way easier to academics who are willing to work with Twitter data. So thanks to these API, you do have access to very specific information related to, for example, a specific location. So in the slide, you can see that we have the possibility to collect data from a specific location. So United Kingdom in general, and Wales more specifically, if you like. Then another thing you can do is to select and filter the data you get to a specific time period. And this is one of the advantages of using this new academic API, that gives you the possibility to even access historical data, so going back in time. And so having the possibility to collect data at specific space in time is an unprecedented opportunity to collect data at population level in order to so this foster plenty of research questions actually. So once you do collect data from Twitter, the specific information they retain is not just related to time and location, but also you do have the textual information itself. That's the content of the tweet itself. And so essentially, the second part of data collection involves a step in which you do have a text analysis process, in which you collect data, sometimes using very specialized processing, considering the fact that Twitter text is not general text, it's a social media text, so to speak. So that is short text. It's the capitalization of words is important, and there's also links and what is known as being hashtags to mark topics usually. And so after the text analysis process, what you can do is to pass on this information to specialized algorithms known as sentiment analyzers. So in this particular case, we're seeing an example of a popular one, which is VADA algorithm, standing for Valence Aware Dictionary and Sentiment Reasoner. And the idea of VADA algorithm is very simple. Is first, it has to be said that this algorithm has been specifically designed for social media data, so for shorter text. And the idea of this algorithm is that given a text and input, it provides you a score related to what the algorithm thinks the text is expressing, a positive, a neutral, or negative sentiment. And there's also an extra piece of information this algorithm provides, which is called the compound score, which is meant to be a sort of unique score generated for a single text, which combines the three sentiments. So essentially, what you do is once you have all the tweets collected, you can associate a score to each of those tweets. Ultimately, in order to do some analysis, for example, in cross time. And Nina and I have been working on specific tweet suites, which is publicly available online if you want, that sort of collects all the steps into one unique package for you to use and for your own analysis, provided you have access to the academic API, which is as simple as submitting a very short application to Twitter, explaining the goal of the project and what you want to use the API for, essentially. We're not expecting actually to find all the answers in Twitter, and just to give you the full picture of our project is that we want to study how effective is using Twitter data in order to understand a population mood and well-being, but at the same time, we also wanted to see how this data is effective in being combined with other type of data. And this was part of our ongoing effort, working in collaboration with Public Health Wales during the COVID-19 pandemic. We started developing this project we called COVID-19 Community Response Map, which is available online. And essentially, the idea of the project was to develop a data analysis tool, data science tool, which combines time-sensitive data with other type of data in order to explore in real time community support and need organized by different local authority in Wales. So more specifically to the Twitter data we're talking about, the aim in this study is has been organized in three separated three different research questions. So in the first research question, we want to understand whether there's any correlation between Twitter and so the use of social media and digital exclusion. Basically, in our study, we consider two measures as representative for the digital exclusion. And we have the proportion of patients in HGP surgery registered with the My Health Online system in May 2020. And The second list we have is the number of people who have regular access to internet from the National Survey from Wales 2018 and 19. Each of these two measures were compared to the number of unique people tweeting over a considered time period, and then aggregated by local authority. The second research question I'm going to present you is the test the efficacy of forecasting mood and well-being between local authorities at one single time point. So remembering that we said that Twitter has an unprecedented possibility to give you access to time and space at the same time, we initially analyzed this data considering one single time point at different geographies. And so the third, as you might expect, research question is actually going to analyze the other case. So changing time, so the efficacy over time. So in particular, the very goal of this research question here is to understand which particular measure of Twitter sentiment is most effective in predicting the well-being across Welsh local authorities at a single time point. And so remembering the different scoring values we could get from sentiment analysis like Beta, we're essentially aiming at understanding what is the most effective measure to use, having so many choices here, like positive, negative, neutral, and compound. And so, as anticipated, the last but not least third research question will be well-being in Twitter across time. So testing the efficacy of forecasting mood and well-being across all the local authorities and across time. And in this particular case, we're going to use data collected from the Britain's mood measures measured weekly, which is a very interesting data set publicly available, which gives information on a weekly basis, which is particularly interesting for the kind of analysis we had in mind. So very quickly showing you results on the first research question. Here you can see that on the left-hand side, the registered GP online, and on the right-hand side, the internet access. So remember, we had two possible data sets we might want to consider as proxy measures for digital exclusion. And so in this result, it shows that the correlation between number of accounts per area and people registered with their GP's digital service do not correlate. Whether there is a correlation, considering the portion of population with internet access, we see that they actually are correlated, and that the correlation rejects the null hypothesis that there is no relationship between those two variables. In terms of the second research question, to assess the sentiment prediction across local authorities, we use data from the Wales Wellbeing Survey, which goes between the 9th of June and the 13th of July. It considers 12,900 participants, so almost 13,000 participants, which measured general well-being using the Warwick-Edinburgh Mental Wellbeing Scale. And distress. And using this data, we aim to test the correlation between well-being and distress with positive and negative compound measure measured on Twitter across all the Welsh local authorities. We found that the most successful result was that compound Twitter sentiment, that is essentially a single summary sentiment score derived by Vader algorithm, was correlated with measure general well-being. And we also found that the measure distress was correlated with negative Twitter sentiment and compound Twitter sentiment as well. It was interesting, though, that positive Twitter sentiment was not correlated with well-being. Therefore, we can conclude that compound sentiment is the most useful attribute in Twitter textual data to test with time series analysis. Compound sentiment is also beneficial since it is actually a single measure, and so is more easily summarized as two different measures, and is more straightforward to interpret, actually. And so, as briefly mentioned, we use the data from the British Mood measured weekly for this third research question. For this study, we collected data from the 1st of March to the 31st of October 2020 across Wales, considering a total of 2,074,000 tweets generated from 41,000 individual accounts. So with an average of 259,288 tweets per month. That is the data set we're talking about. So this data can be briefly mentioning the reference data we considered. So the Britain's Mood Measured Weekly. That is a project to measure the mood of British public on a weekly basis, run by YouGov, and that is to test the potential for sentiment score from Twitter to forecast mood over time in the Welsh population. So this data can be disaggregated to the Welsh population in particular, with a sample of approximately 100 different people answering each week. And YouGov's methodology involves weighing their raw data by age, gender, social class, region, and level of education. What we did was aggregating Twitter sentiment as a weekly mean, and then generating a linear compilation of the 12 mood values to a single composite value by regressing essentially the values against the sentiment score. The aim of this study is, so the 12 emotions are surveyed like happy, sad, energetic, inspired, optimistic, and content, and along with apathetic, frustrated, stressed, bored, lonely, and scared. So those are the 12 emotions we considered as input correlated to, and we actually are aiming at understanding whether those might be correlated to the Baylor compound score generated from Twitter. And in order to enforce this correlation, we also used a statistical test specifically suited for time series analysis, which is called Granger causality test, which, despite the name, is not necessarily related to any causal analysis in particular. There's what we can. We've been using this test to because this is specifically suited for time series analysis. And what we demonstrated is that the Twitter sentiment is Granger causal with respect to the composite mood prediction, whereas the inverse of the relationship doesn't hold. This is particularly interesting because there's what these implies is that the Twitter is actually providing signals of mood up to 3 weeks before this mood is reported by the population. So we thought this was an actual interesting result that demonstrates the benefits of using and the potentials of using data gathered from social media to study population data. And so now I'm hand over to Nina for the second part of this presentation.
Hi everyone. So I'm going to talk to you a little bit about a project we've been doing alongside this one, which is linking Twitter in a UK birth cohort study, and in this case it's a cohort study called Ausback that's based in Bristol. And the reason we wanted to do this is because a lot of mental health data science in this area, so specifically social media, tends to suffer from a lack of access to ground truth data. So a lot of what we end up doing with social media, we get very large sample sizes, but we suffer from not actually knowing very much about the people that we are including in our samples. And obviously, as we get closer and closer to being interested in using these techniques for actual uses in real life outside of just research interesting results, we really want to know who these kinds of methods work for. We want to know what the biases are, and we can't do that unless we know who our samples are. And so what this project aimed to do, and this is led by Claire and Oliver, and it's been going on for quite a few years now. It's involved a lot of software development. It's involved a lot of collaboration with the cohort, with the participants of the cohort. And it is now kind of come to the point where we have the linked data. And Ausback itself is a birth cohort study. It's based in Bristol, and it involves at the moment participants who are approximately 30 years old. So they were recruited, or their parents, mothers were recruited 1991 to 1992. And there are about 14,900 people in Ausback altogether. So next slide, please. And so just to illustrate how this works, we've, as part of this project, got a bespoke piece of software that's been developed just for cohorts who are interested in collecting Twitter data. And hopefully that will be extended in the future to kind of incorporate other types of other digital phenotypes, so potentially other social media sites or other types of digital data that we might be interested in collecting through APIs. At the moment, what it does is collect Twitter data through the APIs that Valerio described earlier. It then also does the textual analysis inside the environment where that data is collected, and it can then output anonymized data to be linked to existing ALSPAC data. And the important reason that this all kind of happens with a specialized piece of software in a specialized place is because cohorts have data safe havens. And Anne was talking about kind of the importance of those environments earlier. This is just very specifically for the cohort, so that data that could potentially be disclosive, as social media data can be very disclosive about people. It can be checked, it can be verified before it's sent out to researchers to be used. And all of that process takes place where the cohort can control it. So next slide, please. So the Linkage kind of consent campaign went out in 2019 to 2020. And overall, we had, from those people who did use Twitter in ALSPAC, a 19.6% consent rate. And that seems relatively low, like compared to having much higher consent rates for other types of studies, but actually it's quite consistent with other Twitter and digital phenotype consent rates for Linkage in these sorts of studies. So we were quite pleased with that. Obviously, there are always errors with these sorts of things. So about 179 people had either private accounts, so you can't access private accounts unless people give you very specific access to those, which we don't have, or just errors in usernames, which is fairly standard. And so of those people, we had both parents in the ALSPAC cohort. So those were the mothers and partners who were first approached to take part in the study, as well as the actual index children who we shouldn't call children because they're 30 and they don't really like being called children anymore. But just for ease, that is who they are. And just to give an example of how representative the data is, because that's one of the first things we were concerned about, is actually, are those 19% of people representative of the people who use Twitter in ALSPAC? And we're fairly confident they are representative. And again, this is consistent with other studies that have found that actually, on the whole, people who consent to having their data linked have actually been representative of the people who use that social media platform, which is a really good sign. So you'll notice that there are different levels of men and women in the study, and that is just down to attrition in ALSPAC and cohorts over time, which again, James was talking about earlier. So yeah, next slide, please. And so what we can do now that we have linked data, we can do some I guess some things that we aren't really able to do without that linked data available to us. So one of the first things we wanted to do, and this is keeping things like fairly simple for now. You can get into quite complex territory with mental health prediction and with all the different variables available. But firstly, what we wanted to do was just see if sentiment, as it is, as you can calculate it from tweet text, is actually related to mental health and well-being. And what we saw from what Valerio was showing was that it is giving us signals of emotions that people are feeling that they're reporting on a weekly basis. But emotions, as they're being reported week by week, don't necessarily translate into like clinical signals of mental health or necessarily predictive of things like increases in demand in health. So that's what we want to explore more with this data and what we can explore more with this level of data. So this is just an example of some of this stuff that we've been trying out. So this is looking at two different time points where we have depression measured with the Moods and Feelings questionnaire, anxiety measured with the GAD-7, and well-being measured with the Warwick-Edinburgh Mental Wellbeing Scale, with the same people at two different time points. And we looked at their tweets for the previous 4 weeks from both of those time points and basically wanted to see if their sentiment goes up, so if they appear more positive in their tweets, does that actually correlate with their mental health changing to be more positive? And that's one way we can just test whether or not sentiment is giving us an accurate read on these things. And actually what we found is so far, anxiety is the only thing that appears to be correlated with change over time. So both depression and well-being don't appear to be. So there is a chance that what we're picking up when we're looking at population trends in mental health using sentiment, we're picking up some signals of changes to mental health, but not necessarily all of them. And another interesting thing we wanted to look at, which is part of the reason for doing this linkage, is who this is actually working for. So if we're using sentiment to predict or try to predict or understand changes in mental health, are there people that's working really well for, and are there people that that's not working for? And so far, for example, with this experiment and these changes, they're not biased by sex, so male or female. They're not biased by whether or not they're the parent generation or the child generation, and also the number of tweets doesn't appear to have any influence on whether or not someone was correctly predicted. So that's something we're keeping a really close eye on, and we're going to be doing hopefully a lot more experiments around that as well in the future. So next slide. So a lot of this study is a lot of next steps and a lot of things we want to do with the data, and we're excited to be doing. It's an interesting process because we're working with the data team as we go and working out how we develop these methods of safely sharing this data. And that's one of our next steps is something that Valerio is working on, which is a platform or a method for sharing this data more widely with the research community in such a way that people get the data that they want, but we aren't going to risk anything with the anonymity of the participants. So that's one of the things that's really crucial with this, so that actually the whole research community can get the use out of it and really benefit from it. We're looking at kind of potentials, so using more complex algorithmic estimation techniques for actually predicting mental health. And part of that will be linking this to primary care data. So in ASBAC, we have that access to that data, and we'll be able to basically to look at whether changes in tweeting, in lots of different types of metadata and text data, can actually tell us anything about what happens next to people in terms of their mental health from their primary care data. And then, yeah, just also we can do lots of interesting things about seeing how digital data might be able to tell us about what periods of time people are thinking about when they answer surveys and all sorts of questions like that. So yeah, that's what we're working on there. So yeah, thank you very much for your attention and for listening.
Fantastic. Thanks ever so much, Nina and Valerio, and a huge team behind to really fantastic work and really interesting bringing in that type of data into the realms of health and well-being and all of those different aspects. One comment for you can see there in the chats about it is really exciting, but also the care that you're taking to make sure that it's done in a robust and transparent way and a safe way using the TRE environments, I think, kind of a cautionary note. A question from Laura: other platforms, Facebook, TikTok, Insta, are they also capable of using the same data or generating the same data outputs, I think? Yeah, Laura, an important point there about Twitter users aren't necessarily reflective of general population users, are they?
Yeah, that's one of the main things with this, really. Is in an ideal world, we'd have access to lots of different social media platforms and kind of be able, because people will switch between them all within the course of a day, and you use different things for different platforms for different purposes as well. Unfortunately, Facebook, Instagram, WhatsApp, the other things that Facebook owns now, or Meta, are all fairly locked down. So Facebook will only allow research access to those for some very specific chosen projects, and it's very, very difficult to get access to their data, which has all happened since Cambridge Analytica, really. So Twitter's quite unique in opening up access to the data where everyone else has mostly closed it down. So at the moment, no, but we're hoping. There's been a lot of push from different places that they need to be making their data more open, partly so we can research the effects of social media on people's mental health as well. So maybe in the future.
Fantastic, thanks, Nina. Any other questions for Nina, Valerio? No. Thank you ever so much, both and all our speakers this afternoon. So Claudia, James and Anne, and thank you everyone for staying the course. It's pretty tough, 2 hours on a Teams meeting, but we had a fantastic range of participants actually from lots of different organisations, which is wonderful. Wonderful to see that challenges in statistics for public health is something that people are really interested in. We've heard from the use of different types of data, healthcare, education data, social media data, to statistical approaches in using that to address public health challenges, both to understand some of the drivers and the risk factors for that, and including cohort data in that too. And then some really good stuff from Claudia on coherence, but also flagging the points for transparency and reproducibility, not just from GSS, ONS or organisations, but us as well as researchers and statisticians and the wide range of expertise that we've got here as well too. Last but not least would be Jow. I think Jow is still there. Huge thank you to Jow for organising it, and Lucy as well too for setting it all up and making sure that we're all okay on the day. So I think that's it for this afternoon. Thank you everyone, and really looking forward to getting the slides, sharing them all out, and hopefully we've sparked some new connections between individuals and groups as well from this afternoon. Have a good afternoon.